If you guys are all wondering whether you're at the right room, yes, it is. This is the HealthTech Summit. This year, NPC, we have got 6 vertical summits that we are running, which are all based on different verticals that are particularly applicable for India. And this is the first time that we are doing it. And a lot of thought and things have gone through to get the right agenda and then the speakers lined up. My name is Milind Hanchinmani. In a day job, I lead the developer relation division in a software group at Intel and take care of Asia Pacific and Japan. And I'm also a part of NASSCOM Product Council. As people know, that NASSCOM Product Council typically works for Indian software companies, product companies. And in that, I'm part of the council representing Intel. And I lead a deep tech sector. In the deep tech sector, what we have started is really focusing on some of the startups which are focused on the deep tech because they require a lot of different way of handholding and then helping them. So I lead that. And also, I'm supporting and then helping with NPC and leading this particular HealthTech Summit. And I'm going to be your host today. And very excited, to be there. There are a lot of people who have actually worked. Niranjan from Cyclops, Anish Basurai from Healthify Me, and then Yogesh and Nitin and Reva from the Optum team, really helping us to put together this fantastic agenda over the last, probably 2 to 3 months. Okay, so I really thank them. And then one of the questions that comes to everybody's mind: why healthcare, right? And I'm actually talking to some of the people, and then I got some very interesting statistics. I'm not a healthcare person. I'm not into that domain. In our country, the doctor-to-patient ratio is 1:1428. And probably by the time I finish it, it will be a little bit more, right? So tuberculosis, which is TB, kills over 1,000 folks in a year. And that's shocking to me. I was not aware of that, right? And maybe it's even more than that. And then, it's shocking to me. And we are obviously diabetes capital of the world and the heart disease probably capital of the world. That shouldn't be a surprise to any. And with the majority of our population living in rural areas and absolutely no access to the healthcare, whether it's a doctor or a facility, there are many challenges that we have, and many of the solutions that are running in the in the Western world that may not actually work in India because of all the issues that we have with respect to the infrastructure and then the unique thing we have. So that really is why we are here today, with our thinking hats and with really optimistic in our mind to make some changes possible and to really see why, how we can really make the change possible. While we have this great opportunity, great challenges, we also have fantastic opportunities ahead of us, because when there are challenges, there can be opportunity. And particularly with growing population and then, rising income levels, etc. And then the changing disease profiles, the really call for the high-tech med tech can really bridge this gap and then provide a solution for us. And this particular industry is fast growing, and it's expected to grow 5x to be USD 50 billion by 2025. And we have got a really new breed of technologists and doctorpreneurs. This is a new word that I learned today, by the way, who are really developing fantastic cutting-edge AI technologies to bridge this gap and to really help some of these challenges. And today we are here to celebrate some of those new breed of entrepreneurs. We have a fantastic speakers and esteemed speaker lined up. They are going to talk about technologies, they are going to talk about unique challenges and then solutions, and then debating on some of them, particularly about data privacy and regulatory aspect of it. And then finally we have startup showcase or a product showcase. We have got some of the companies coming in and really showcasing of their innovation, and that's the heart of this summit, isn't it? So I'm really excited and really fantastic agenda ahead of us. And with this, I won't take much time. I would like to invite Archana Shukla to really kick off the this summit with a fireside chat. Archana Shukla is an assistant editor, rural affairs and pharmaceuticals in CNBC TV 18. She actually has done a lot of ground level stories on rural healthcare, infrastructure and overall rural economy. And she is specialized in health tech and then pharma. So I think she'll be do a fantastic job with the domain knowledge that she has. And a couple of her stories with respect to healthcare have won her national and an international award. So please, big round of applause for Archana Shukla to kick off the first chat. Archana?
Thank you, Milind, first of all. And this is the first time I will be speaking and talking to, I think, some of the best tech minds gathered in one single room, looking at healthcare or wanting to do something about healthcare when it comes to healthcare technologies. Starting off with a quote, tell me how many of you know who said this. Imagination is more important than knowledge. Albert Einstein. And I think most of you present here utilize the imagination that takes the knowledge up to a different level altogether. And that is where health tech is hoping to bring some sort of disruptions in the entire healthcare market here in India. A few terms that we keep hearing whenever we talk to healthcare, either providers, companies, pharmaceuticals: accessibility, affordability, disruption, technology, cusp. We'll try and bring all of these words together and see where India is headed right now when we talk of health technology, when we talk of providers, when we talk of quality of care and bringing affordable care back to patients. India certainly is, as many people say, at a cusp when we talk of healthcare. But are we really? When the Indian government kicks off a massive experiment of Modi Care or Ayushman Bharat that is to bring and bridge the screening, the preventive and primary health care to secondary and tertiary health care to medical insurance, how far will this medical experiment, this huge political healthcare experiment progress without technology? I guess all of you would agree, not very far. So for India particularly to look deep down into how medical technology can take us from this step to the next and the next, let me call on stage John Santelli. He is the Chief Information Officer at Optum, where he leads the advancement of commercial information technology outsourcing, business processing, software, and cloud services. A company that has somewhere bridged the gap between providers, the insurance, as well as technology, and we'll try and get a lot of perspective when it comes to technology from John. We also have with us Dr. Mudit Saxena. I am told he started his career as a clinician in a primary health center, but now currently he's the managing director and CEO with Ovum Hospitals. It's a chain of birthing hospitals. He's also worked with care hospitals, SGG enterprises, in different segments, in different therapy areas, in different segments of provider care. And he certainly can give us a lot of perspective on what currently are the challenges and aspirations when a provider is looking at technology. So without much ado, let's get started with this conversation. John, we keep talking about technology, we keep talking about startups and artificial intelligence, 3D printing, God knows what not. Many of it I didn't know till maybe a month ago. In your experience, you come from a developed world where technology still has taken a step forward versus a country like India. Just to kick off this conversation, could you help us with one or two examples where you think healthcare technology has really given exponential benefits to providers as well as to patients?
Okay, much better. Well, thank you. It's great to be here with all of you. I think technology is going to, not only today but in the future play a significant role in really helping, the access to care, really the quality of care, and I think really understanding where people are at high risk. And a lot of our focus recently has been how do you identify high-risk patients, because in the States, our clinical or healthcare trend is growing about 7% CAGR. And it's already a big piece of the U.S. economy. And if we don't figure out how to bend the cost curve of our clinical costs, it's going to be 20, 25% of the GDP, which is not a sustainable system whatsoever. And so we are aggressively trying to figure out how do you reduce costs but maintain the quality of care? And how do you know who is the high-risk patients? Because once you become a disease patient, you are one of the highest costs and one of the highest utilizers. And typically in populations, you'll find there's 10, 15% of the population that drives 60 to 70% of the cost. And so a lot of what we're focused on in using technology, particularly predictive analytics, machine learning, is to use big data with electronic medical records, administrative data, pharmacy data, lab data, try to bring that together and really train models that can help predict and identify who out of a population are the highest risk patients. So it's one thing to identify them, it's another thing to intervene and then prevent the disease from happening. I always use diabetes as the best example, and Dr. Mudit would be so much more explanatory here, but the short story is, once you contract diabetes, you have diabetes for life. It is a lifestyle impediment. And then you're susceptible to comorbidities, which is a real challenge. And then if you look at the cost of a diabetic, they're often 2.5 times the cost of a healthy patient. And so they really burden the system. Not only is it not a great life experience to have diabetes, but it also burdens the healthcare system materially. And so we're focused on the predictive models that can identify them. We're also focused on the technology that enables us to intervene. And intervention is the hard part, because intervention is many things. It isn't just a phone call. It can be digital channels. It can be home visits. It can be education around diabetes. It can be getting them into care programs where it's as simple as a weight loss program to help reduce the chance of diabetes. In fact, there's statistics in the states that say, and you can validate this, if you lose 6 to 7% of your body weight, you could reduce the risk of diabetes, type 2, by 50%. So think about that. How hard is that to accomplish? But if you don't know, how would you ever address your situation? So intervention is many things. It's not just one thing. So it isn't just pure technology. I think the technology can, particularly machine learning, really increase the accuracy of the prediction. So we're finding pre-diabetics now at an 87% accuracy rate, which is fantastic. We have the fortune of having a lot of data in the States, and so to train models, with a lot of data, you can get very high accuracy. And so we are fortunate that we can actually find and identify them. But then the real hurdle is how do you actually engage them, educate them, put them into care management programs, weight loss programs. That's the real challenge, and that's not just a technology issue. Technology can help with education. Certainly digital is going to be a piece of that, but there's going to be many solutions to really try and get that consumer engagement for those kind of populations.
Right. You spoke about data, and you said, you are privileged enough to have good amount of data in the US and other developed markets. India is certainly very poor when it comes to data. Talk of any other set of data, and particularly healthcare data, patient data, we really don't have good amount of repository of data here. Mudit, let me bring you here into this conversation with a question particularly on what are the current challenges that providers here face in India when they try to link themselves to technology. Data certainly becomes one, because we don't know, we don't have, even the patient records are not as well managed and well maintained as it would be in other markets. So how does the same technology link onto the ground level scenario here in India?
Thanks, Archana. So I would agree with John in terms of what he was specifying, how technology can be a facilitator. It cannot be the end. Okay, it's just a facilitator in terms of giving a solution to that. In terms of technology in Indian healthcare scenario, I don't think so. It's a very highly regarded one. both by the practicing clinicians, which I have always had strong kind of conversations when I do with the clinicians. They have strong, I would say, abhorrence when it comes to documenting their data. They would always say that technology takes a lot of time. I could have seen 2 more patients rather than doing all this kind of work. Why can't I get an assistant who does all this kind of work? So their thought process is that as a clinician, I'm more efficient by talking or just scribbling it on a pad and then moving forward. And when you're not documenting these things, there is no repository for tomorrow. So I don't think so the feeling goes in terms of a repository and a long-term sense of creating a data pool and looking at the society per se. They are more or less talking about a day-to-day transaction where they feel that they've seen a patient and they've addressed his needs and moved forward in life. That is one. Secondly, of course, I find most of the doctors are technology savvy. You find the doctors, they'll have the latest gadgets in their hands. They'll all be on WhatsApp, they'll be on, you tell me any of the communication channels, they'll be very, very frequently accessing it. I've seen doctors accessing Facebook more often than the number of patients they've seen in a day. And despite that, when it comes to going for a patient care module, they would not be very comfortable. And I think at times they also feel challenged because whatever they're getting writing or saying will get documented. So they also perceive it as a threat, and I don't think so. And if I now go back into time in terms of my mid-school days, we were never actually made tech savvy from that point of view. We were always told that you have to write a big answer, you have to do this. So everything was on paper-based documentation. And I don't want to go and open something which is slightly irrelevant to the current conversation, which is the education system in medical schools or colleges. But it is very important to understand that the current scenario, when it changes, the same development has to go retrogressively as well as progressively. And I don't think so that point of time has been initiated in the schools or the med schools.
Not even still today.
Some of the private medical colleges I've started seeing are adopting to it. Unfortunately, the government medical colleges where we have all passed out and come from, we still have a old school kind of a thought. The only thing which has changed is that I don't have dissections anymore. It's more of a virtual dissections which we do now. That's all.
Mm-hmm. But you know, with Ayushman Bharat coming into the picture, the need for linking technology to healthcare becomes even larger. If Ayushman Bharat actually has to take off and actually benefit patients and providers together, I guess, you know, to deal with the supply issue, to deal with the time issue that you were talking about, technology will have to play a role. What's your view on that?
I agree. I totally agree with you. But let's understand the Indian healthcare scenario, and I think it's very relevant before we jump into the pool of technology or service providers or anything. I think right in the beginning of the session, they were mentioning the data indices. And just to refresh our memories, I'll roll out some numbers, but not it's not carved in stone that you have to remember it, and I'm going to ask you questions on that. In India, we have 7 per 10,000 population doctors. So 7 doctors per 10,000 of population. WHO recommendation is 15 per 10,000. Let's look at nursing. We have 25 per 10,000. WHO recommends 25 per 10,000. We have 12 per 10,000. If you look at the number of beds, we are 13 per 10,000. WHO recommends 25 per 10,000. So these are, if you look at it, India is just at half the mark, both in terms of, and when I told these numbers, it was basically, if you look at a healthcare service, there will be a service provider, which is a doctor, a nurse, and a hospital, which is an infrastructure, which is the number of beds. Then I look at the person who's going to utilize the service, which is the patient, and that is a 10,000 population, which I marked out. We have grown tremendously, you know, the current rate at which we are growing. We will be overtaking China, I think, by 2030 and 2025. And China will then start declining by 2030. And then India will take over the space from 2035 onwards till 2067. We will be the most populous state in the world. So look at the amount of human capital which is going to sit there. Now, when you launch out schemes like Ayushman Bharat, what are you doing? You're making Indian healthcare, the major challenges are in 2 folds. 70% of the Indian healthcare is by private sector. private sector is inundated with problems like technical skills. We have a very limited set of skill sets. These are doctors or nurses which keep moving around from one hospital to another. We have issues which are regulatory in nature. Government comes up with new policies overnight, stent prices controlled, this will be controlled, you cannot sell this at this. So a private enterprise which is invested would look at a return because banks have rolled them or whatever it is. Public sector hospitals, they have their own challenges. One is quality. The quality of care in public hospital is really very, very challenged. Someone talked about accreditation. About 500 NABH hospitals are listed in the NABH website. Please tell me, if you have had a time to count, how many of them are government hospitals? And is NABH only for private healthcare providers? It is an accreditation board for hospitals.
But you know, these are the challenges that somewhere technology can,
Absolutely
seep in
right.
and fill the gaps that currently exist in the Indian healthcare.
Absolutely right, Archana. So when you look at the challenges coming here, when you do something like Ayushman Bharat, what are you doing? You are increasing the demand because you're creating accessibility for a lot of people. But the provisioning is still remaining the same. The bottleneck in India is not only the affordability bit, but also the provisioning bit. And I think technology will be the bridge there. Today, when you're looking at this, I see a lot of, if you look at something like in Bangalore or Hyderabad or Delhi, the indices of doctors, beds and nurses in Bangalore and Hyderabad is equal to Japan. We have 35 beds, whereas WHO says 25. In Hyderabad, Bangalore, we are sitting with 35 beds per 10,000, which is it's better than a developed nation. So what happens? You have an infrastructure there. Similarly for doctor ratios also. There are a lot of doctors who are being in a metro because they don't want to go to periphery or rural areas. They are the ones who can technology be enabled to start looking into these areas.
One of the data points suggested that 70% of Indian doctors service only 10% of India's population in urban markets. So it's the remaining 30% that service the 90% of population in rest of India. So certainly there is a huge gap as far as supply is concerned when it comes to technicians, when it comes to doctors, when it comes to providers, and certainly quality of providers. But we've seen a couple of startups in India taking that step forward to link and bridge this supply gap. Bring the doctor, the specialist who's sitting in a metro center or in an urban center through telemedicine or through different sort of technology to a rural setup. John, just help us understand, in India we are now trying to bridge this supply gap with technology. There are startups that are doing it. And in turn are, collecting all the data available as far as patients is concerned. You spoke about how technology can help link the high-risk patients, how you can, screen them. Where do you think a country like India could, go with this technology, but also face some sort of challenges from the experience that you've seen in other markets? So what could be the challenges when we are talking of this big level of data now being collected? We don't have an experience of managing data till now.
Yeah, I think it's a great question, and I'm not sure there's a perfect answer for it. I would just tell you, I think Dr. Mudit said, and I'm just going to call it out, every health system has really three key issues: cost, quality, and access. And everywhere I've gone in the world, that's been consistent. Those are the kind of underlying issues. And I think India in particular is challenged because of the demographics and the population and the infrastructure. I think what might be interesting for India to think about, particularly the technology folks, is can you leapfrog over the top of kind of the current technologies? Are there ways to use mobile? Are there ways to use medical devices? Are there ways to actually bring care from the care centers like Bangalore perhaps, where they have capacity, into these rural communities by using devices, by using phones? I think it's going to be hard to predict disease without having rich data sets. So I think Dr. Mudit said it, the use of the EMR and building that database is absolutely critical for the future, to use that data, mine that data, find the patterns of care, find the the quality elements of care. So I think your investment on EMRs is absolutely essential, and I think Dr. Mudit hit it perfectly. But I think the challenge is you're going to be faced rationing care if you can't figure out how to bring this capacity to bear into the rural communities. And I'm going to actually ask Dr. Mudit to speak, but he mentioned to me before, even a new class of care workers, if technology could help educate a new worker that perhaps is a physician assistant type, where technology can bring that to the rural communities and help the supply side. Maybe you don't need physicians in every marketplace. Maybe with the medical devices you can, in rural communities, administer, using a different class of worker, the telemetry that's needed for a physician to make a decision. I know now in the States, some of the virtual care technologies, the physicians can do 70–80% of the procedures without even touching the patient. So about that, is that a way to address some of the supply issue? Is that new opportunities to grow the Indian marketplace in rural areas? And then how do the technology folks here start, help the EMR data, start to be populated and help maybe the digital aspects and the telemetry and remote monitoring and remote kinds of needs in order to do bring the capacity to the rural areas into the home solutions. That'd be kind of my immediate response.
Yeah, with ECG now coming on iPhones, yeah, I think healthcare is now really reaching, it's at your palm. Mudit, with so much of grassroots level innovation now, starting to happen in India, we've seen that take off in other parts of the world, but with this level of grassroots level innovation, and with also large, medical technology driven innovation on a larger scale, where do you think the median will be for a market like India in the coming times?
I think that's a very, very interesting question. When you look at the Indian healthcare scenario, I think when you look, the Indian customer is a very cost-conscious customer. Trust me, when you tell him that it's a subscription model, he needs to see the value in that subscription model. So when you talk to startups who are bringing up various technologies and stuff, they say that we'll do subscription models or we'll do these models. I agree with that, but you need to be very price sensitive on these issues. India is a volume market and the margins are lower, but if you do larger volumes, you can make it viable. Because I personally feel the intention, first your intention, the objective is to serve the people in terms of the needs of the people. Second is you have to be viable, so then only you can continue to serve people. So these two are essential for any business plan. Now going about in terms of how do you see the growth of these, whether it's in rural setups or it's in metros. Rurals I've seen, so I don't know if each one of you are aware of the Swasthya Slate. So Swasthya Slate did something phenomenal where they did about more than 55 or 70 parameters with a backpack which is solar paneled. And healthcare workers are moving into remote areas of Jammu Kashmir, Kumpwara and those hilly regions where healthcare workers were earlier not being able to go or the doctors can't reach. And these guys go and do dry chemistries. If you will go to the database, they were able to show tangible difference in maternal mortality rates. And I think when you tangibilize that data, it has a lot of value in terms of healthy mothers, healthy child being put forth. Currently, I'm seeing a similar trend in metros where you're seeing online consultations happening. I'm talking about an eNICU. So I'm running a hospital in a remote area right now. And we're able to restructure from the price point bit so that I'm still able to compete with the rural market with the same price points, but a better branded service. And then the cost, he asked me, how did you bring the cost down? I said, the way I brought the cost down was, I'm doing eNICUs. So I have got a nurse there, but I'm also doing a remote monitoring with a neonatologist who continuously monitors the NICU there. And he gets the same value over there. In HCG, in my previous organization, Vishal is here and he's going to talk about it too, I hope. When we were doing this, we went to a tier 3 town, which is like 350 kilometers from here. You have to run a PET scan image. The PET scan images were actually, you take an image there, it was sent to a central control room over here. The physicist would draw the whole cancer treatment plan here and send it back. So next evening it will come to us. Overnight they will do the whole treatment planning for the cancer patient and then you send it back. The challenge was if I go and put a treatment plan, radiation therapist planner there, it is going to go to a cost of about 1.5 to 2 lakhs per month, and I can't make it viable. The project is not viable on that price point. And technology, I see a great facilitator there, because not only it brought down the price point, it made me give the same service levels which I was doing in Bangalore to the person in Gulbarga or Hubli. And we are still getting the patients, from patient's point of view, the experience in both treatment and service levels has exceeded his expectations, and he sees the value for money. And from my end, I also see a larger volume to cater to and make my business viable. So I think technology would be the great, kind of a joint player which will.
So improving clinical outcomes as well as making it more affordable to the patients, that is where, before I open this panel for Q&A from the audience, I just want to get one bit of a perspective from you, John. With your experience, huge experience on the insurance front as well, where does the insurance bit come in when we have so much of patient level data? We have improving clinical outcomes, like Mudit was pointing out, when we use technology. What role does insurance play here, and what can be the learnings for India now that we are embarking on this huge experiment of Ayushman Bharat that looks at medical insurance at a large level for a large mass of population?
That's a great question. Thank you. I would tell you that it's very interesting, the administrative data that comes out of insurance, the payments, the reimbursement aspects, is very longitudinal. It gives you kind of a view regardless of what health system a patient was using or what pharmaceuticals they were on or what emergency rooms they went to, because typically, you can have people access the system in a number of different places. It gives you a very good longitudinal view. It's not very deep clinically. And one of the things we've embarked on is working with provider communities that have EMR data, which is very deep clinical data. So if you think about combining the data of the administration, which is this longitudinal view of diagnosis, procedures, and the deep clinical view where you have deep biometrics and clinical notes, that gives you, particularly the provider, a better view of the patient. And what we're learning is that in the American health system, we have a pretty vicious cycle that's going on here. And I mentioned their cost trend of 7% CAGR. What happens is the sponsors of care want lower costs. Why do my clinical costs keep going up every year? Mr. Payer, do something about that. So Mr. Payer turns around and says, Mr. Provider, you need to lower your rates. And Mr. Provider lowers his rates, but he has to make profits too. And so what happens is there's a lot more utilization. And then the clinical costs keep going up, not down. And so the system doesn't work. It's actually incestuous in some ways. So what we're doing with marrying payment data with clinical data is actually collaborating payer and provider community and using that data to find the high-cost patients together. And instead of the payer-provider relationship being one that's adversarial, it's one that's becoming collaborative, because together we can share in the risk of the patient population, and together we can manage, using that data, the high-cost patients and getting them into care settings or to care programs that we can address those high-risk patients more proactively. And so, I think the learning from that for India could be very positive. Don't let your insurance system get into a cycle where it's combative. Rather, I think you need to have a collaborative view of where you can share data. I mean, sharing data, I talked about it this morning, interoperability of data, the ability to reuse labs and radiology and payment data, all of it matters. And God knows what's going to happen in the future. I mean, we talked about device data, your social data, the devices that, your activity monitors in your phone. I mean, the data is going to come from everywhere. And so I think as you, look at the data you do have, maybe you don't have administrative data, but you may have other sources of data, financial data, telemetry data, that can start to help predict or help identify these opportunities. So
the problem India has is not lack of data, it's lack of managed data. So somewhere I think the FMCG industry has really used the data that's available to its advantage. Healthcare still has to. Mudit, you have a point to make,
So
I guess.
I think fair point, and data transparency is something, I learned it from the IT industry. When you guys started sharing your data across, there has been an increase of about 4 to 5% productivity in your various companies across, because they started seeing each other's data, and that so
Learning
you
from
learn
each
from
other,
each
yeah.
other. So I think that's the key over here, what he mentioned. And from technology perspective, I think, as he rightly said, from insurance, it's a longitudinal data. I think going by the current technology platforms, if you look at blockchain coming in, that will be a great help, because then you can actually see the whole growth chart of the patient right from the point of his birth to the transition. So it not only builds up a huge phenomenal epidemiological profile and a cohort, you can continuously go around, study and data mine and bring in interventions, both from pharmaceutical aspect, because that takes almost about 65 to 70% of the cost in the outpatient sector in India,
Right.
as well as intervention part.
Right. At this point, we can take a few questions from the audience. First of all, just 1 second, sir. Just wanted to understand what's the profile of our audience here. Are you all health tech companies, startups, students, companies? Yeah, it's a mixed bag, but all focused on healthcare, or are from different segments as well? Mostly. Okay. Hospitals, so provider care as well. Okay, okay. Yeah, sir, can we have a mic sent to him? Would request you to introduce yourself, and if you are pointing the question to any one particular.
Yeah, the question is to either, and probably more to Dr. Mudit, because he's from India. Because the question is related to India, not because I'm preferring an Indian or something.
There's no pinch of nationalism in that.
Absolutely, absolutely. Okay, my name is Ajay Mia. I, besides running an IT company, I also run an IT health tech startup. So with 80% of healthcare in India being in the unorganized sector, there has been a huge resistance and reluctance amongst the doctors in adopting any sort of EMRs. They are not interested. Their first questions are, how is it going to help us? And when they say, how is it going to help us, it's more to do with short-term rather than a mid-term or a long-term gain. And if you are not able to capture the data that comes out of these 80% plus doctor-patient interactions, all the tech talk that we are doing is related to, by and large, the organized sector, which is handling maybe 20%.
Right. Absolutely.
Now, this is on one side, okay? And pardon me for a little longish question, but there's a second part of it, and I would request you to address both. The second part of it is, we are a country which has such a shortage of doctors. At the same time, all of us know how hard a doctor's life is. Forget about getting admission into a medical college. He will spend years trying to get a post-graduation degree, and then he still doesn't have a job. Okay? And then he tries to set up on his own, and if he gets into the unorganized sector, he is worried about his patient inflow. And in the context of that, adopting technology is something which is much lower in his order of priority. So in this scheme of things, how do you think any change or transformation, or what change or transformation could possibly help this situation to make tangible impact on the ground? Thank you.
Sure. So to answer the first bit, you asked me, why is there a strong resistance among the practicing clinician team, the world, especially in India, for this? Most of the times when I have talked to the doctors and I've seen them, I'll be slightly cutthroat in this. In an hour, he sees about, say, 10, 15 patients. When you give him an EMR, if that number drops down to about 8, he's highly unhappy, because he loses the revenue around it. Because he feels if he's going to just go write A, S, D, he keeps typing this, someone has to do it for him, he's okay with that.
May I interject at this point?
Yeah.
Okay. We know, there are doctors, particularly if they're in hospitals, they will have those many patients to see. Okay.
Right.
But go into private practices, and you will have a whole lot of doctors who may not be seeing even between 5 to 10 patients a day. Okay. And even those people are significantly reluctant to adopt anything because they will have the problem of, hey, I don't have patients, what will I put the data in?
Absolutely right.
No, but then also I think the question comes in, if a doctor is not seeing enough number of patients, does he really want to invest the money in technology too?
So,
sorry, I disagree with that for a specific reason, but let me first hear from him.
I'll be very clear. My understanding of the clinician fraternity, when I keep interacting with them, part of them who are highly busy, they would always ask for someone to assist them with all this database, which I keep finding with my doctors. The guys who are not doing something great, they still feel that if this is coming free or it's going to be a beta site or something, can you talk about it? Otherwise, I'm pretty happy with my 10 patients and I can work around with that. So that's kind of a mindset which runs there. Secondly, the transactions which are happening are basically cash transactions there. Usually they are not something which is happening through an insurance-based or a provider-based, where you have a legislative coming in which says that you have to document data. In India, that's one of the biggest challenges. The moment you have an insurance case, we all start typing, writing the medical history and doing everything. The moment we know it's a cash patient, the documentation becomes, it'll be there in the medical records, but it's not there. Secondly, going by the court orders and going by the Indian judiciary also, they are saying that documentation of data is fine, but despite that, you will have to manage the medical records in the paper style also, you still have it. And if it's a case which has been a medical legal case or something, you have to maintain the whole file. It's the digital data form, archiving it is okay, but putting it as a digital format is not acceptable to us. So those are the kind of legal challenges or the regulatory challenges which makes them feel why to go around and bother ourselves. That's what I find a kind of an inertia amongst them for going for this kind of a technology. The second part.
Okay, yeah.
Sorry. I'm sorry, she has cut me down, but I would...
No, go ahead. Of course,
sorry.
yes. We're just running short on time, we'll maybe want to take one more question.
Yeah, so you can ignore the second part, but just complete this one.
No, that's okay. Then I can't, so that's fine. Sure.
Okay. We have too many hands going up.
Take one question.
Yeah, okay. From this side, I'll take. The gentleman with glasses. Oh, both of them are with glasses.
One is with beard, without beard, you can answer that.
With beard.
Hi, my name is Vibhor. I work at Loomis Partners, which is a mid-market private equity fund looking to invest into healthcare. I think, Mudit, you made a very valid point that Ayushman Bharat, affordability is not the only challenge, provisioning is. I'm looking to invest into some kind of primary healthcare companies, more towards the tier 4 cities, tier 3 cities, around the villages as well. But I'm just kind of curious if you have come across, what kind of business models you see emerging in these areas. And is there a play large enough for private players? Which I'm sure it is, but I'm not sure about the business models.
It's almost like a consultancy kind of a question. To tell you very frankly, from the cost, you have to evaluate every business model there. Tier 4 and Tier 3 are one of the most dynamic environments because the cost of competency is very high in those markets. And but rest of the costs you will have to revisit, right from acquiring land, rentals, and all those kind of. So those are the things, margins, etc. So I think you will have to evaluate. You also understand the product, which product you are entering into. Are you going into a generalized, that is a multi-specialty hospital, or are you going to a single specialty? And in single specialty, which product? Where they're looking at oncology, cardiology. So all these kind of things happen. I think it's a detailed question. We can have this offline if you don't mind.
Makes sense.
Okay.
Yeah, sure.
Considering the paucity of time here, but I've still negotiated for one more question with so many hands going up. But we'll take one question from the gentleman here in the 4th row, I guess. Can we have the mic? Please keep your question brief. Is the only request.
Hi, I'm Afzal from BestDoc. PRM or a CRM for hospitals maker. My question is towards John. In US, you would have seen the EMR adoption jumping from about 8% in 2008 to about 95 plus by 2015, about 7 years time. Could you just give us some hints on what were the key drivers which made this jump happen so that the health tech community in India can look at some of those game changers?
Yep. You may not like my answer, but it actually was government incentive. There was a policy that was legislated called meaningful use, and they gave great incentives to the provider community to demonstrate adoption. And what happened was the provider community saw this as the one-time event where, okay, let's bite the bullet and let's go in and spend the money. At least we'll get some break from the government, and this is the time to do it. And it became a thing that everybody was moving towards quickly. And then I would just tell you that the timing was right because payment is such an issue, and being able to use an EMR system to articulate services rendered was kind of at a peak point. And so you have the government paying providers to make a change, and you have the incentive of them being able to charge more completely for all the services rendered. So it was like a perfect storm for them to be incented to make the change. I will tell you though, they hate the EMR, the providers hate the EMR systems just as much in America as they do here, although they're forced at this stage with compliance, even the way they get paid. EMR data is now part of, contractually how they get reimbursed. The government programs themselves force, the medical record to be part of the reimbursement policy, and so it's become more and more intertwined with payment. So I think until you start having payment incentives or the need to specify, all the services, because it's very often the provider does so many things, only half are captured, and they're leaving money on the table. So until they figure out that that's a method in which way they can get reimbursed, it's very hard to have them change their mindset. But I think Dr. Mudit was right. Everybody's productivity with these new EMRs, they're not new, these EMR systems that are old actually, all went down. So I do think there are technology opportunities to come on top of these with workflow, with NLP. There's got to be better ways to help the physicians, solve these very difficult problems with, seeing patients and maintaining productivity.
Well, it's always little, when we talk of time, there is always little when you want to speak on a subject as large as health technology. I'm really sorry. These people will kick me out of the room if I take one more question, but all of your questions offline can be handled by John and Mudit, and I'm sure there are many people here in this room who would want to sit around the table and chit-chat on technology with a very, very cliched line, but something that suits the current scenario here in India is this is the time that healthcare has to embrace technology to actually take the leap forward. Look at the challenges, look at the examples from other parts of the world where they may have gone ahead or even faltered, and learn from it and take it forward. With that, on that note, thank you so much, John and Mudit, and thank you so much, audience, for your time.